Thank you everyone for joining and welcome to our session on personalized predictions and prescriptions for COVID-19 patients. My name is Agni Urfanudaki.
And my name is Holly Weiberg, and I am a fourth-year PhD student. Agni is a fifth-year PhD student at MIT's Operations Research Center. As was mentioned, today we'll be presenting on work that we've done on both risk prediction and personalization of treatment for COVID patients. This is joint work with our advisor, Professor Dimitri Bertsimas, as well as many members of our research group and clinical collaborators from various partner institutions. So just to give a little bit of context to start off on our work, back at the beginning of the pandemic, as COVID started to surge across the world, there were many questions that emerged as to the disease dynamics and how to best combat the pandemic. And our team at the Operations Research Center saw an opportunity to leverage machine learning and optimization to help answer these questions. We were eager to contribute to this pretty rapidly developing global research effort. So in the months since then, we embarked on a research effort that has spanned many areas, including medicine, epidemiology, and policy. Today, we'll focus specifically on the clinical side of things, and two projects in particular that we'd like to highlight. One is the prediction of COVID-19 mortality risk for hospitalized patients, which I'll start off with. And then we'll move over towards the prescriptive side of personalizing treatment specifically for hypertensive patients, which Agni will present in the second half of the talk. And we look forward to discussing this all at the end, so feel free to put any questions in the chat and we can talk about it afterwards. All right, so to get started with our mortality prediction tool. As we all remember, early in the pandemic, there was little understanding of COVID in terms of the risk factors that might confer severity. And as hospitals were overwhelmed with demand pretty quickly, there were questions as to who to prioritize care for, how to allocate resources, etc. And so this led to a rapid effort by various research groups and clinicians to try to understand what were the determinants of severity to better prioritize resources. There were apparent similarities between COVID and other diseases, but there were also apparent differences. So researchers began to try to study COVID patients by starting with generally cohort level analyses. So looking at groups anywhere from 10 to 1,000 patients and trying to understand through univariate analysis generally, what were the differentiators between severe and non-severe COVID cases at these different facilities. This began to start to provide characterization of the disease, but there were limitations to it. First, patient risk is inherently nonlinear. There are different ways that these individual risk factors interact to determine a patient's trajectory that can't be completely captured by univariate statistical analysis. There were also questions about generalizability. Due to the timing of the pandemic, most of this early work was focused on cohorts in China, but as the disease began to spread globally, it was unclear how well these initial models and findings would extend to new populations. So our research group, which has spent the past several years working on predictive analytics for healthcare, saw this as an opportunity to leverage our methodologies to help fight the pandemic. Specifically, we set out to develop a risk score that could be used to triage patients and to predict mortality upon hospital admission, with the goal that this could be used by clinicians in practice to help improve care that was being delivered at the time. There were three key aspects of this work: data aggregation, the use of machine learning models, and finally, clinical engagement. And the project really couldn't have succeeded without all three of these aspects. That without the modeling, without the data, the models wouldn't be useful. Having this large-scale data allowed us to make robust conclusions. And at the same time, if we didn't have clinical engagement, we would lack credibility with a clinical audience. And so over the next several slides, I'll go through the three aspects of this work. starting with the data. So our goal here to start off was to create an international collaboration of various institutions to form a diverse cohort of patients that represented groups from both Europe and the United States. We began collaborations with groups in Northern Italy, throughout Spain, in Greece, and also in the United States, which reflected a broad range of hospital congestion levels, population characteristics, and other things that gave us some diversity to our population. And at the time, it was the largest, to our knowledge, multi-center cohort of a large Western population. We've started with this raw data and went through several steps to form our final clinical feature space. As anybody who's worked in clinical decision support tools has probably experienced, there's a lot of data cleaning that goes into forming these feature spaces. And that started with just the raw data itself. We had different data sources depending on the site that we were collaborating with, either electronic medical record data or COVID registry data. There are trade-offs that EMR data is generally much more granular, but it lacks standardization, whereas the registry data was a lot cleaner, but limited in the features that it collected. So going forward, we had to look at these two different sources and find commonalities to form a data set that could be reflective of the entire population across these sites. We began by extracting data for our relevant population, which was COVID-19 confirmed cases, adults who were hospitalized at one of our partner sites. We then went through some extensive data cleaning. Since we were working with different international organizations, we had to begin by translating the records into English and then defining universal clinical concepts to ensure that when we're talking about a lab value or a comorbidity, we're speaking about a consistent definition across all of our sites. At the end of this, we were left with a data set of 33 hospitals and comprising almost 4,000 patients. Our derivation cohort consisted of patients from Northern Italy, Spain, and the United States. And our validation cohort consisted of 3 separate institutions in Southern Spain, Greece, and the United States. So here we have a lot of numbers, so no need to get too far into the details. But with this data set, we formed a clinical feature space of 22 features that were available early within the admission. We looked at demographics, some basic comorbidities, and labs and vitals that were taken within the first 24 hours of admission. The choice of the feature space reflected our clinical prediction task, which was to be able to identify a patient's prognosis early within the visit so that that could be used to inform triage, resource, and care decisions. Our outcome of interest was, as we said, mortality, and we defined this as a binary outcome of mortality within the hospital admission. So any patient whose visit terminated in death was marked as a 1, otherwise a 0, and this had 25% incidence in our derivation cohort, noting that we were working with pretty congested systems at the peak of the pandemic. So our outcome rate is pretty high from this data. With this feature space, we then moved into the machine learning portion of the modeling. And we can go through more of the details of the model, but essentially we trained various algorithms ranging from linear models to ensemble methods, and ultimately settling on an XGBoost model. We made this decision based on a pretty sizable edge in quantitative performance and accepted that there's a loss in interpretability of natural interpretability that we get when we do this model. And we'll go into how we kind of deal with that in the next few slides. So once we had our final model, there were 2 key aspects of our evaluation. There was the quantitative evaluation as well as the clinical evaluation. From a quantitative perspective, we took pretty standard binary classification metrics. We looked at the model's discriminative ability through the AUC, and we also looked at threshold-based metrics with a focus on model sensitivity. We did this analysis on the derivation cohort as well as the validation cohort, noting that from our experience with previous collaborations, that clinical decision support tools really need this external validation on unseen data to validate that they will be useful on new populations and deployed in new settings. We then moved on to the clinical interpretation. So while XGBoost is inherently a black box model, we were able to leverage Scott Lumberg's Shapley additive explanations framework that he introduced a few years ago, which is able to assign risk contributions to individual features at a per patient level. This insight could then be shared with clinical collaborators who could give us insight into how our algorithms findings validated existing clinical findings and potentially extended existing clinical knowledge. So we'll start by looking at the quantitative evaluation. Our first metric to look at was the model AUC. And here you'll see we reported the metrics on our derivation cohort, training and testing set, as well as our 3 validation cohorts. So looking at this, we see that we're able to obtain an AUC of over 0.9 on our test set. And looking down at the validation sets, we see our AUC ranging from about 0.81 to 0.92. Interestingly, the Seville data set has an even higher AUC than our derivation test set. We see overall, while there's a slight loss on some of the validation sites, which could be a function of differing levels of hospital congestion or differences in the population, we still see strong performance of over 0.8 across the board. We then look at the threshold-based metrics. We focus on sensitivity here to ensure that we're being conservative and not missing any potential, or not missing many potential severe cases when patients are admitted. In that way, we enforce a sensitivity of 80% in our model, and we look at what is the highest specificity that we can obtain within that constraint. So as you can see, looking at this, that constraint results in different thresholds and different specificities that are site-specific. On our testing set and on the Seville data set, we're able to obtain specificities of over 85%, with slight losses on the Hellenic data and our Hartford Hospital. But we think overall, this framework provides a way of thinking about trade-offs between sensitivity and specificity in potential deployment to new sites. That individual sites may have different priorities on sensitivity and specificity based on their levels of congestion, their capacity constraints, and also their assessment of costs associated with false positives and false negatives. From here, we move on to the clinical side of our insights. And as I mentioned, we're looking at the SHAP framework by Lundberg, which leverages Shapley values from game theory to assign individual risk contributions to each feature for each patient. This gives us a sense of the magnitude of feature importance, but also the directionality. So we'll go through a few different plots that start to characterize the clinical insights, starting with this summary plot. So here, we're looking at a plot that shows the 10 most important features in descending order, starting with age. If we look at this graph, we see that the SHAP value plotted on the x-axis, where a positive SHAP value indicates an increase in mortality probability, and that ties to the feature values through the color scale. That a blue value, which is the lowest, or a blue color, the lowest value of a feature, as we move from blue to red, we see what direction the risk changes. So for age, for example, as we move from blue to red or low to high age, we see an increase in risk. So a positive correlation between mortality and increasing age. In contrast to oxygen saturation, where we see that lower oxygen saturation is associated with worse outcomes. We then go into a layer further to explore this through these dependence plots, which show for an individual feature, as that feature value varies, what is the risk contribution across all patients in that population. For reference, we've also plotted the normal range in gray to show to contextualize the values. There's a lot more clinical detail in the paper, but just to give some of the quick takeaways. First, we see that elevated BUN and creatinine at or above the normal range bounds are both associated with worse outcomes. These are both measures that can reflect poor kidney function, which has been shown to be a risk factor in severe COVID-19. We also see a positive correlation of risk with C-reactive protein, or CRP, a common inflammatory marker that's also been implicated in infectious diseases in recent years. We see with oxygen saturation an interesting trend that when a patient's oxygen saturation is within normal bounds, there's a slight risk mitigating effect of this feature. And as we decrease oxygen saturation, patient risk continues to increase below the bounds. And finally, we see that with blood glucose, that out of the normal bounds of blood glucose, there's an increased risk. Blood glucose is a proxy for diabetes, and diabetes has been shown by several independent groups to be a potential risk factor in COVID-19. So at the end of the day, as I mentioned, our goal here was to create a tool that would be practical and could be used to inform better decisions in clinical practice. And so the final step in this translation to practice was the development of a decision support tool in an online interface. You can check it out here at this link, but basically we've developed this tool where a patient or a provider can enter the clinical features for themselves or the person they're caring for and get their mortality risk prediction directly online. We once again leverage the SHAP values to get personalized insights into drivers of risk for these patients. So for example, for this one patient, we see that their age of 75 is something that's increasing their risk or contributing to higher risk, whereas their blood glucose, which is in normal bounds, is a slight risk mitigator in this case. In the months since we've developed this tool, the model has been implemented in the electronic medical record of our Seville partner institution, which is involved in a network that serves almost 7 million patients throughout the Andalusian region. That our tool is now being prospectively validated at these sites, and so hopefully as we continue through the fall and into the winter, we'll be able to continue this validation to get more insight into the model. So as I began, there are 3 key aspects of this work: the curation of an international cohort leveraging multiple data sources, the use of state-of-the-art machine learning methods for both model training and interpretation, and the development of an interface that provides personalized risk scores and insights in an easy-to-use way for both patients and clinicians. A natural next question would be, now that we understand who is at higher risk, what can we do about that? In particular, are there ways that we can prescribe treatment in a better way to improve outcomes? And that's where Agni will take it from here.
Okay, so let me share my screen quickly. Are you able to see my screen? Okay, so let's move now from the predictive to the prescriptive analytics setting. My objective is to guide you through our efforts on using machine learning to personalize the use of ACE inhibitors and ARBs for COVID-19 treatment. So as we have seen and Holly described, the COVID-19 pandemic has put an enormous strain on healthcare systems around the world. And therefore, it is of critical importance to be able to understand how patients will respond to various potential treatments. And while the race for a new vaccine and antiviral drug continues, many researchers focus on repurposing existing drugs for the treatment of COVID-19 patients. Dexamethasone is assumed to lead to reduced mortality rate in severe cases that receive oxygen support, while remdesivir is the only antiviral drug with promising results so far. There is still lack of consensus regarding the use of other drugs, such as hydroxychloroquine or corticosteroids. However, a particularly interesting case is the one of ACE inhibitors and ARBs. ACE inhibitors and angiotensin receptor blockers are one of the most commonly prescribed treatments to address high blood pressure and heart disease. And the latter have shown to be 2 of the most important comorbidities for COVID-19 patients. However, initially there was concern regarding potential side effects related to the use of these drugs for COVID-19 patients due to their chemical compounds. But multiple clinical investigations from various countries showed that neither ACE inhibitors nor ARBs were systematically associated with an increased or decreased risk of in-hospital death or severe COVID-19 infection. Our assumption was that one size fits all does not apply in this setting, because given the complications of COVID-19 to the cardiovascular system, we could ask the question whether ACE inhibitors or ARBs can be beneficial or even detrimental to specific subgroups of hypertensive COVID-19 patients. In other words, we are thinking whether we could personalize their prescriptions. So how do we do that? Suppose that Jane is admitted at the hospital with COVID-19, and the question is, should we prescribe ACE inhibitors or ARBs to Jane? We take a look at her clinical admission values and medical history, and as Holly described, we can process the data to standardize its format and impute the missing values. We can use multiple machine learning models to estimate what would happen to Jane under both scenarios. And we prescribe to Jane the ACE inhibitors or ARBs only if our model suggests that they will decrease her chances of dying or experiencing any complications. Our goal is to develop and validate a prescriptive algorithm that identifies whether an individual like Jane that suffers from hypertension is likely to benefit from the use of ACE inhibitors and ARBs for COVID-19 treatment. In order to achieve this objective, we need data from multiple sources to ensure that our results are generalizable to different demographics. So we combined electronic health records from HN hospitals and AST Cremona that we showed before, as well as Mass General Brigham from Massachusetts and the International Hope Registry. Our final data set comprises almost 4,000 observations from 69 hospitals located in Spain, Italy, Germany, Ecuador, and the US. Our derivation population, as you can see here, include all patient samples from Spain. And that way, we ensure that the reported results in the validation cohort provide us with a good proxy of the model's performance in distinct patient cohorts from different geographic regions. We compiled a set of 32 features, including demographic information, medication history, inpatient medication, comorbidities, and lab test results. And here, our outcome of interest is not only inpatient mortality, but also morbidity. Morbidity refers to an adverse event during hospital admission, including heart failure, acute renal failure, sepsis, and an embolic event. And its prevalence varied from 20 to up to 35%, depending on the site. So let's give first an outline of our approach. First, we construct the patient database from the international collaborating institutions. And for each patient, we determine three things. First, her clinical features at admission X. Second, the binary outcome Y. And third, whether she received ACE ARBs with the indicator Z. Then we apply a matching algorithm on the derivation cohort to create two similar treatment and control groups with the same baseline risk. The next step is to train several binary classification models to predict patient risk under each treatment alternative. Our goal is to prescribe this medication only if it leads to a decrease in the patient's risk of mortality and morbidity. And to measure their effect, we aggregate model predictions through a voting scheme. And thus, we recommend the therapy if and only if the majority of the methods agree. So let's deep dive into these steps. Matching is a method that can be used to control for confounding in observational studies. The motivation of this technique is to find groups of treated and non-treated individuals whose pre-treatment characteristics are similar, and then to create models using only these individuals. By minimizing the differences in pre-treatment characteristics, we become more confident that the outcome estimates that we see can be attributed to differences in the treatment assignment rather than to pre-existing differences between the individuals in the treated and non-treated group. Balance is measured by comparing the pairwise absolute standardized mean differences in covariates. And as you can see in this figure, we achieve pairwise balance between the two groups below 0.05 for all covariates considered. In blue, you can see the results after matching, and the squares indicate our results prior to matching. So there is a clear improvement in the balance of the two cohorts by applying this process. Using the matched data sets, two sets of models are constructed to predict a patient's risk of mortality and morbidity. One set of models is trained on patients who were given ACE inhibitors and ARBs, and the other one on patients who were not given these drugs. For each treatment, we train 6 binary classification models to predict the patient's risk for the outcome of interest. But the question is, how do we leverage them in order to provide a recommendation for a new patient? Now let's go back to the example of Jane. Suppose that we apply a regression compare approach for each one of the different algorithms individually. The optimal classification tree models suggest that ACE inhibitors and ARBs can lead to better outcomes for Jane. But CART suggests otherwise. Gaussian naive Bayes votes in favor of prescribing the medication, which is contrary to what random forest suggests, that does not identify any benefit for Jane by prescribing this class of drugs. However, both quadratic discriminant analysis and gradient boosted trees recommend the use of ACE inhibitors and ARBs. In other words, each method casts a vote, and our algorithm is going to recommend the option for which we are most confident about. In the case of Jane, it suggests ACE inhibitors and ARBs with an expected risk of mortality morbidity of 14%, which corresponds to the mean of the values of 0.15, 0.20, 0.11, and 0.10. So we have adjusted our methodology so that the algorithm recommends ACE inhibitors and ARBs if administering the treatment is predicted to have a reduction of at least 5% in the probability of an adverse event. The improvement threshold is intended to reduce unnecessary prescriptions. Because if the patient's predicted risk is nearly identical under both treatment alternatives, just like the case of random forest we saw before, we do not recommend the treatment, and thus we avoid unnecessary prescriptions for the patient. To assess our analysis, the first thing we did was to look at the discrimination performance of our predictive models. And here you can see the AUCs for the 6 binary classification algorithms for both groups. In general, the models for predicting outcomes with the medication have higher performance than those for patients without this medication. And as you can see, random forest and XGBoost are the highest performing methods overall, although all algorithms demonstrate AUCs above 0.7 across all models and above 0.8 in most of the cases. Now, measures of predictive performance, although necessary, are not enough. A prescriptive performance evaluation scheme needs to be far more comprehensive. Good prescriptions should decrease the incidence of mortality morbidity rate in our cohort. But every patient was prescribed either the treatment or the control in practice. And as a result, counterfactuals are not known. In other words, we only have data on the treatment received by a patient, and we cannot know what their outcome would have been under the other treatment option. So we performed this assessment in several ways. First, we focus on prescription effectiveness, and that way we compare the actual event rate to the average predicted risk under our prescription scheme. So if the raw mortality morbidity rate is 30% and the average probability of mortality morbidity in our data under our prescription scheme is 25%, then the PE, or prescription effectiveness metric, is minus 0.05. And so here negative values indicate improvement. Now, there is a problem here because PE could be biased in its estimate of the outcome probability since it compares what happened in practice with a machine learning estimation. So in other words, PE does not compare apples to apples. Prescription robustness takes a more objective view. It uses a single machine learning method to evaluate both the outcome probability under the standard of care and the probability under the prescription. So for example, let's use a CART for prescription robustness. It would compare the average expected outcome as predicted by CART for the proposed treatments versus what CART is predicting for the regimen that the doctors recommended. Switching gears, another way to evaluate our recommendation is to report the proportion of our prescriptions that match the true treatment decisions, and so see how close we are to what happened in practice. For example, if out of 100 patients, 60 of our treatment recommendations are consistent with what the doctor suggested, then the agreement rate would be 60%. An alternative measure is to go back to the predictive setting and look at the AUC of the risk probabilities for our prescriptions. So of course, this metric is limited only to the treatments, only to the patients for which our algorithm prescriptions agree with their true treatments, but it still gives us a very good proxy of how accurate we are on what we are suggesting. So how well does our prescriptive framework perform? So here are some of the key findings. We recommend ACE inhibitors and ARBs to approximately 41% of the validation population. There is a reduction in the mortality morbidity of at least 0.2% across all datasets based on the PE metric. And according to prescription robustness, the benefit from individualizing the treatment can reach up to 3.5%. We agree with what the doctor is suggesting at the standard of care approximately 50% of the time. And notice also that the AUC of the recommended prescriptions are higher with the ensemble approach versus the individual models that we presented before. And intuition of that is that the same way when we use random forest, aggregating multiple card models is more accurate. If we aggregate into our predictions of the prescriptive outcome many different algorithms, we can actually get better AUCs. Can we also get some clinical insights to understand how we are changing the treatment patterns for our patients? These figures show the observed and the proposed frequency for ACE inhibitors and ARBs treatments under the current practice with blue and our prescriptions with orange on the validation data. Our algorithm recommends an increase in the overall number of prescriptions for ACE inhibitors and ARBs. And that includes suggestions to hypertensive patients who were not originally prescribed this line of therapy, as well as patients who were already prescribed this class of drugs. The benefit of personalization is also that our algorithm identifies patients where getting this regimen might be detrimental. And so in subfigure A, you can see that the algorithm recommends a higher ACE-ARBs prescription rate for patients with cardiovascular disease. And this could be highly impactful given the prevalence and potential consequences of heart disease in severe COVID-19 cases. Our prescription scheme overall recommends raising the prescription rates across all age groups, and in particularly for younger patients below the age of 40. Moreover, we notice that female patients are more likely to benefit from this class of drugs compared to men. Now, the next step, as in the case of the mortality calculator, is the development of dynamic online application. And we are currently creating a user-friendly interface, such as the one that you see here, to communicate the results of our algorithm to clinical providers. And our new website our new page will soon become available at the COVID Analytics platform over the course of the month. So to conclude, our approach establishes strong evidence for the benefit of individualizing ACE inhibitors and ARBs for COVID-19 patients. And by personalizing the prescription of these drugs, we are able to improve patient outcomes even by 0.5% in the worst case scenario versus the standard of care. Now, given the magnitude of the pandemic, our algorithm could help clinicians save thousands of lives around the world, even for a small improvement in the mortality and morbidity rate. Our framework also avoids unnecessary drug prescriptions that would have limited efficacy, and we hope that with our interactive interface, we will be able to enable broad use by physicians and healthcare organizations across the world. Now, I would like to stop here and say that I believe our work is a key step towards a fully patient-centric approach to COVID-19 management and the utilization of existing treatments to reduce its toll on public health. If you're interested to read more about our work, here is a list of all the publications associated with these investigations. And feel free to access our covidanalytics.io website to find our analytical tools and reach out to our team or to us personally if you would like to discuss this further. Thank you very much for your attention, and we're looking forward to the discussion.